Hello and welcome to South First. I am Chetna Belgire. Today I am in conversation with Karnataka's Health Minister, Mr. Dinesh Gundu Rao. Thank you very much, sir.
Yeah.
So, healthcare in Karnataka was a major topic during the recent legislative sessions. Do you believe the state's healthcare is under crisis?
No, I will not say it's a crisis, but there's always, scope for improving, and there are a lot of things that I think we can do to improve the healthcare. And Karnataka, in terms of in national averages, we are well ahead of that. But when we compare ourselves to our southern neighbors, especially Tamil Nadu and Kerala, I think we need to catch up and do a little bit more. So I think definitely there's lots to be done, but I won't say it's a crisis, but we can do a lot to improve.
Okay. So with increasing maternal deaths, I'm sure, there was a
Yeah.
huge hue and cry about it. Now, there is this fear, all said and done, despite you giving a lot of assurances and despite clarifying a lot of things, there is a fear kind of, people do not trust government hospitals in terms of maternal care and things like that. So there are people who are saying that we don't want to go to a government hospital, we're afraid to go to a government hospital. What is the government doing about it to reassure public in this front?
See, I think what has happened in Ballari, that incident, has really, I think, caused a lot of mistrust and also lack of faith. The reasons for the Ballari maternal death to happen, we've already spoken
Yes.
about it. The fact that we feel that the drugs that was used was of poor quality, and it's all that the doctor's fault. That was also our findings by the expert committee, that no doctor did any mistake. It was due to some other reason, not due to the medical reasons. And that, I think, became a big issue. And since then, see, maternal deaths in Karnataka, it's right now it's at around 64 MMR, compared to, say, Tamil Nadu, it's around 44, 45. And Kerala is like very, very less. Kerala is, I think,
Less
around
than-
20.
Yes, correct.
So that's the we've been having a downward trend on MMR since many years. And actually, we are our decrease. I mean, our improvement in MMR is the fastest in South India. But that means we have to do more. So what's happening after the Bellary incident? Any maternal death that is taking place is making news. It is a good thing. I feel there should not be any sort of laxity, or every death is something that is we need to look into. We have a maternal audit system, but I think a more vigilant hospital system is needed. I think people may be right now feeling that what's happening, because it's coming out in the newspapers. Like some of the newspaper articles, they were talking about absolute numbers, and like in Belgaum, they said 320 infants had died. But Belgaum has got one of the best IMRs.
Right.
But they take the absolute number and they made it into a big news. So there are couple of aspects to this, but I think slowly we are also evolving a new policy, so that how we can improve maternal health, and how we can improve the mortality rates, and how we can improve the facilities, and how do we check each and every maternal death properly, and what are the real reasons. We want to have zero preventable maternal death, basically. That is our goal. And we are working around the policy, and I think sometime in Jan, we will be coming out with it. So that where are the gaps in the present system? That is being looked into now by 2-3 committees. So we want to at least try and address those gaps and fill those gaps, so that we do not lose out on the mother's life,
Yes.
and of course after that the baby's life. So we are looking at addressing those gaps, and I think once we do that, I'm sure people will gain more confidence. But I think we cannot blame the people, because when these things happen, it's a very sensitive subject. But I think it's up to us, our doctors, our department, to really gear up and do better. And I'm sure we will be able to win back the trust.
So this maternal death issue has brought in two major issues. One is, of course, the drug, like you said.
Yeah.
Unfortunate, it's the
Yeah.
drug which was supplied and that went. But it's very easy to just say it and say that it was the drugs. But is there anything at all that the government is now looking at in terms of policy to monitor the drug? Because once you there was a huge discussion about this
Yeah.
also in the assembly about how there is a court order which is brought in, and then there is nothing which the government can do. But then what is it that the government is now thinking? Because once the court order says no, we can go ahead and supply these drugs, is it still possible to scrutinize it? How do you plan to do this? Because
See,
it can happen again, right?
See, if, there are two issues. One is we need to improve our medical supplies corporation, so that whenever we buy medicines, there should be more regular checking of the quality of drugs. That is, of course, needed, and to see that we have right systems in place. I think there may be, like you said, for example, we found some of the drugs to be of poor quality. Then they get it tested by the central drug lab. Central drug lab says it's good quality, and then the matter is closed.
Correct.
So there has to be a third way, because once we find something is of not of good quality, NSQ, and if the another lab says it's of SQ, then there has to be referred to a third party again and double checked. So there has to be another mechanism we need to evolve if there are two conflicting reports, and that is one thing. Second thing, more random checking is second thing. But I think one of the most important parts also is to ensure the quality of medicines being supplied and the manufacturing facilities. That I think is very important. And unfortunately, in India, the drug regulatory system is not robust. It is not. It doesn't hold the pharma company liable. There have been so many incidents, even recently in Jammu and Kashmir, few days back, there were incidents, and they have come out with a finding, and they've stopped, supply of certain drugs by certain companies. And we saw in so many other cases where people have died or people have fallen sick, all those things, and the drug quality has been poor. So the drug regulatory system has to become more strong. And if someone is found to be supplying NSQ, there should not be any compromise in saying, no point in just fining that pharma company, say some amount, and them getting away in the courts. What is the point? Because the extent that it's gone now is when pharma companies supplying abroad have got a certain standard, drugs which are exported, and drugs for India got a certain standard. There should not be a compromise on standards. Whether it's for a poor person, rich person, whatever, quality should be there should be no compromise. So that I think I've already written to the drug control department, drug control of India. Our department has written, and actually I wrote an article also in the newspaper in Prajavani,
that's why I wanted
saying
to ask
how we can bring about transparency. How do we know which are the companies which are failing? This data should be available publicly, so that offenders or pharma companies who are major regular offenders, they should be caught, or they should be scrutinized more deeply. And those who have been, say, blacklisted, we have no clue. Like I may blacklist somebody in Karnataka, someone in Rajasthan will not know I have blacklisted, because it doesn't come out there's no central database. So I have suggested that the central the drug controller should have a national database where every state, whatever we find, is uploaded, and it's easy for us to figure out. Many people don't upload, many people don't mention it, and it's very difficult for us to know. So that is transparency is one. Second thing is making the pharma companies accountable, and if they fail, the action against them should be stringent. But we don't do that. In fact, it's the reverse that is happening in our country. We want to protect pharma companies. We want to support them, because pharma is a big sector, huge lobby. Second thing, India is worldwide known as a great pharma base, because we supply generic drugs all across the world, and so our companies are well known. So government is at some point of government at the back of its mind. Any government, I'm not blaming this central government. All central governments have somehow tried to protect the reputation of our pharma companies. They don't want it to get spoiled. So when something happens, they will somehow try to see that it is resolved and doesn't really become a big issue. Whereas actually it should become a big issue. That's why even in this Ballari incident that's happened in Karnataka, could be some failures of the Medical Supplies Corporation, but we don't want to hide anything, and we want this to become a big issue, because people should know, and the pharma company should be held accountable, because people have died. Right. And when people die, you just can't be held. You can't just go scot-free. Right now the company has been told to stop manufacturing. There was a inspection by the central drug team, our team, West Bengal team together, and they found discrepancies in the manufacturing process. So they've asked them to stop manufacturing. Right now it is stopped, but
Can state do something about this, sir? Can state interfere and actually look at, whenever you're taking a tender, or when you're assigning something to such things to the government hospital, then can state actually do all of these things, do these checks
yeah, see,
thoroughly, and
we do checks.
once there is a discrepancy found in, like suppose there's a
Yeah.
substandard drug, then completely stop it from the state level, by the state level? Can they
See,
do
we
that?
can we can stop the supply. See, suppose a drug is declared NSQ, the action should be that that drug should be the supply of the drug should be stopped.
Yes.
Suppose if it's a government supply, then we can take action. Like we can book a case. We will seize the drug. We will try to take it back and ask the pharma company to replace it. That's what happens.
Yes.
And some prosecution case is booked, and most of the cases get dragged on for years. Only a few of them will reach the end result, and most of the prosecution, the ultimate conviction will be that some fine, and the most of the convictions have been that till the judge rises from the seat on that day.
Right.
That's the period of conviction. So that is one thing. So we need to. I've told my department that suppose a drug fails, whether in the drug department does random
Right.
checks.
Yeah.
Any drug fails, and I think the rule says if 2 failures are there, then you can take action.
Correct.
So we should be able to take action, not only stop the supply, but in this country there is no system of recall. Suppose a drug is of poor quality, it's gone into the market, we don't take it back. We may stop the supply, but what about what has already gone in?
Right.
So we need to bring everything back. So there has to be a methodology of having a recall of a poor quality drug, especially if it is going to cause grievous, consequences. I think that's what we are working on now, to have a proper protocol where anything NSQ, there has to be, okay, with some like spurious, then that's dangerous. Adulterated drugs, spurious drugs, like you heard in Maharashtra, the antibiotics which are spurious.
Right. Yes.
Or some are of poor quality, that is, they have endotoxins, or they're not sterile. Drug is of not spurious, but it's not made of, the manufacturing process is not good. So we need to take action on that. So we need to have a proper protocol, and that is being put in place now.
Also, another thing which this incident also gave rise to is also the kind of C-sections that is happening in the state.
Yeah.
And also, it showed us that it needs the investigations have shown that it needs life course investment. It's not just
Yes.
that one.
Yeah.
So is the government doing
Yeah,
anything
we
on
have already, this actually, we've been discussing it before this incident took place
Right.
also,
Yeah.
because I was finding that cesareans are increasing, and especially in the private sector more, government also it is. So it is like some hospitals are doing at 85, 90% cesareans.
Right.
So, I mean, that is not acceptable. So there are two things. One is, we have to, basically when someone becomes a mother, or when she becomes pregnant, and she's childbearing, there has to be a process of, building confidence in that person. Preparing them psychologically, physically, that you have a natural, unless there's a complication. So what happens with us, that preparation is not there. There's not much preparation which the gynecologist will do, or our health workers will do. So when they come, and this is an easy way, cesarean is the easy way out, and it's less taxing for the doctors and the staff. It's just like, you cut open the stomach, take the baby out, restitch it and finish. Whereas doing a natural childbirth is, you got to prepare more, you got to put in more effort, there is a period of labor, so all that. So there is more effort, and there is less income. A C-section, the hospital earns more money, and it's a much easier process, less effort. So it's a double advantage they're getting by doing a C-section. So one thing is we're looking at is how we can incentivize financially to do a regular birth, even within government also. Because in government, we don't give them any charges to the hospitals. We don't pay anything under ABRK if they do a regular normal childbirth.
Right.
But if they do a C-section, then they get some money. The hospital gets some money. Even under private, when they go to a private hospital, if they're doing a C-section, if it's an empaneled hospital, then they get our insurance. So how do we do that? That is one. And how do we ensure that the mother to be is prepared? So that we need to bring in more. Our department, women and child department, I think both have to work together in trying to see that our preparation of the pregnant woman, is there has to be a proper way of handling it.
But accessibility is also a concern. Like, in rural areas, what I've heard is many of these districts, by the time they come there, it's too late. And the doctors themselves are also, like you said, they don't want to take a risk and
Yeah.
they immediately jump in for C-section. So has there been anything
Yeah, so
thought about?
there is a thought about this because like we say now, when all this is becoming news, so doctors are going to get even more scared.
Yes.
They say if suppose something goes wrong,
Correct.
I'll be held liable.
Yes.
So why take a chance? Let's do a C-section.
Correct. Yes.
So that fear also shouldn't come in. So we have to also at the same time bolster the confidence of the doctors and the supporting staff,
Right.
the staff nurse, all of them, and the anesthetist, gynecologist, all of them. So we need to bring them into, but they also should be held accountable. So two things. So, and I think, see, in the West now, if you see, they prepare the person. They emphasize on natural childbirth. So they tell them, do these exercises, maintain your nutrition, monitor everything, see that the baby is getting good nutrition, the mother is getting good food. So, and plus some exercises. So I've been telling my department
I think it was the same here way before.
Way before, there are no options, so they were doing it. So
no, they were promoting natural birth.
Yeah.
India was known for
natural birth. So today I think it's people also are getting scared, and younger people now, they are also getting scared because they don't want to go through that process of thing. So you got to prepare them psychologically, And I've been telling our people, we have Ayush people, we have Ayush doctors, we have yoga doctors. So teach them some yoga asanas, teach them some exercise. So by doing all those things, they become also physically also it improves, but mentally also they become stronger. So they'll prepare themselves for that. So that is where I think we are lacking. So
I think facilities is also something which the department should think about, sir. In some of the, especially the tribal, they have to come all the way till Chamarajnagar, and then especially
especially in these kind of areas.
Yes.
That's what we are discussing. That we need to have, whenever there are the pregnant women, they should be addressed in a different way, because either when we know the approximate dates, suppose if they say they've given a particular date, at least 10 days before that or 2 weeks before that, there should be regular monitoring with that person.
Right.
So checking their symptoms, checking how they're feeling. So in case, if need be, you bring them in earlier. Or another thing you can do is we are discussing is that can we in these kind of places bring that person in a few days before the date of delivery, so that she can be in the hospital for 4 days or even for a week. She can stay there, and instead of rushing, suppose if it's a far off place. So these are the things that we are discussing. So we'll be coming out with a comprehensive policy kind of a thing next month on how, basically to have zero preventable maternal deaths. And also for cesarean also, what all we can do in terms of policies and in terms of our rules, how we can promote a natural childbirth, what are the things that we need to do, so those things we will be coming out a detailed one.
Okay, so KC General Hospital is something which has been in news again this time, because you've spent crores of money there to beautify it and bring in some infrastructure and all that. Recent Lokayukta raid showed that it's really in a very bad state. So anything on that, have you
see Lokayukta, I mean, some of the things on that day, I think what is happening now, a lot of work is happening and new buildings are going to come up, all that. I think, what happens is certain things that they look at, and there will always be some discrepancies. Like they'll find some medicines which are, say, some of them may be expired, which are kept there. So they have not bothered to remove them or whatever. And certain medicines which are normally in government should be not for sale.
Right.
So here they are outside medicines. Yes. So, but what happens is we are allowing our hospitals to go and purchase from outside, because we are not able to supply all the medicines. So we tell them, you buy it from outside and give. So that medicines will not have this kind of marking. So these things are there. So Lokayukta finding, we are also, wherever in good interest only, public interest only, they will do. But I think, whether it's KC General or whether any hospital, like for example, recently there was one mother in Belgavi who was shifted from Hukeri to the district hospital, and she
She
passed away.
passed away.
But why she couldn't be treated in Hukeri? Because the gynecologist was not there. The gynecologist was supposed to be staying in the taluka headquarters. She was not staying in the taluka headquarters. Anesthetist and gynecologist both were staying in the district headquarters or outside. So that is a gap.
Yeah.
So our doctors, we have to hold them accountable. We should them a notice now. But the
Life
person
is
is
gone.
life is gone. And many of our doctors, they don't stay in the talukas. They stay in better
Yeah.
bigger towns. But we as per law they have to stay there. So these are the things that we need to really fix.
Yeah,
Yeah.
and again, when you're talking about the doctors not being there, again it brings us to the fact that there is again the staff shortage, and then
See,
the
staff
hiring.
shortage is one,
Yeah.
but there's not staff
This is not
shortage.
shortage,
The staff
of
shortage is
course.
something that
Yeah.
which
So
we
it's
have.
been an ongoing thing.
Yeah,
I mean, I'm
yeah.
sure there is a lot of recruitments and call for that is happening, but then still the ones like the CHOs, the roles they've been given, they're not being able to do those roles because of multiple things they've been doing, administrative work, and
Yeah.
then patient care becomes a problem
Yeah.
with multiple schemes to be implemented.
Yeah.
So is there anything being done in
We are now
regard to human resources?
Yeah, human resource we are augmenting now. We are taking another some 220 specialists and doctors are going to be recruited, and these ANMs, PHCOs, and HIOs, the health inspecting officers. Government has given permission for about 1,600 to be hired now. So right now we're taking them on contract, and recruitment as and when it happens, they will come and replace these contract workers. So that permission has been given. We want to actually increase the salaries of these MBBS doctors and specialists. So we've written to the Government of India under NHM, don't increase your total component that you're giving us, but within this funds that you're giving us, give us a little bit more to pay these doctors more, so that hopefully they should give, so that we can on contract whenever we're hiring. Many places they're not coming
Right,
because
the
of
salaries very
salaries
less.
being less. So we want to really increase that, and we also want to ensure that, especially if there is a pediatrician, and if there's a gynecologist, we provide the other two there. That is an anesthetist and a pediatrician. So the triad should be there.
Correct.
No point having one gynecologist one place, anesthetist another place. So that we want to complete the triad.
Right.
And wherever there are high delivery loads, hospitals, we want to see that this triad is operating, and we are trying to look at whether we can make, like in a taluk hospital, we have one gynecologist and I think one anesthetist and one pediatrician. Whether we can make it double,
Okay. Yeah.
so that we run it 24/7, basically. So that people should have confidence that if they're going to go to a taluk hospital, there will be a doctor.
Right.
So many places, like you said, why trust deficit is there? Sometimes if there's no doctors, the word of mouth goes down. No? Hey, our hospital sari illa.
Yeah.
There are no proper doctors there, or they may not be there. So we want to create that, especially now. Earlier it was different, but now I think people can reach the taluk hospital very easily.
Right.
And if it's running 24/7, then I think people will, if they have the confidence, they'll rush there immediately.
True.
They will not waste their time. So we're trying to work on that.
So though this is not your subject directly, but Tamil Nadu has kind of vehemently opposed NEET all the time. What is your take on that, sir?
NEET is not directly my subject,
Yeah,
but
that's
Tamil Nadu also is opposing NEET, but it's NEET, they have to follow NEET because NEET is a national law. So it is under medical education. See, there are advantages and disadvantages to any system. That is, I won't say that there's no advantage in doing NEET, but the disadvantage is also there. The disadvantage is that people from the rural areas, semi-urban areas, or from advantaged families, for them to get through NEET is very difficult, because you need not only doing well in your exams, but then you got to prepare for the competitive exams, and it's like going to good institutes, all those where you can crack NEET. So that is affordable for those people who can afford it.
Correct. So it's snatching away.
So
don't
it's
you think
snatching
this-
away. Earlier, see, to be to be a good doctor, I think is basically you need to have the right aptitude, and if you have the basic interest, then they can become good doctors. You don't need to be a brilliant, intelligent person to be a good doctor. So just because somebody's marks is less,
Right.
doesn't mean he'll not be a good doctor. Once he gets a seat, if he's got interest in subject, he'll pick up. It's not like say engineering or something very technical, where you need to really have that basic that skills or the brain power.
So Karnataka is doing the Griha Arogya is doing really
Yeah.
well. It's a very good scheme as well. So are there any more initiatives of this kind coming in, and
No,
how is this itself doing?
I think Griha Arogya, we want to make it a really a good scheme. It's got challenges, so now we have started it in Kolar and it's gone well, and now across the state it's going to get implemented. So I think that is something which, in terms of focusing on how we can prevent on preventive healthcare, is where I think government needs to focus.
Yes,
Our
absolutely.
focus tends to be always on the curative
Curate.
side.
Yes.
But actually, on the curative side, there are hundreds of people who are doing curative work.
Correct.
We are doing, nursing homes are doing, private hospitals are doing, medical colleges are doing. There are 100 options for people.
Correct.
Only some will go to government, some. But in the preventive, who's doing? Who's going to do?
Right.
There is no money in it.
Right.
So it is primarily the role of the government. Of course, there are some NGOs, well-meaning NGOs, some foundations which are there, but they can't do at a, they can take up a
Grand scale.
district, one taluk, one here, there. But across the state, only government can do, and that should be our focus. The thing about preventive health is there's no immediate return to the government. Now, if I start doing something, the benefit is after many years. Whereas all political leaders, they want to showcase what they've achieved immediately. So, but anyway, that's the important thing. Then, of course, we are working on the maternal health and child health. I think we really need to focus on that. To make it, we need to bring our numbers at par with our neighbors. Really bring them up. So that will going to become a major focus for us. And of course, we've got other schemes that we are doing. We want to see that some of the things that we're trying to do is see that our specialists who are there, they are actually doing the work they're supposed to do. We want to mentor them, so mentoring programs for them, and we give them the facility. Say, suppose there's a dentist in a government hospital. What are the procedures he's doing? Why he is not doing all the complicated procedures? Okay, if he has any problem with the equipment, we'll give them the equipment. Whether it's a dentist or an ophthalmologist, or say a surgeon.
Right.
We want our surgeons. Say orthopedic surgeon. He should be doing knee replacement.
Right.
He should be doing hip replacement. Why are they not doing it? They just do some simple complex fractures, do that, and the rest they send off them. But we want our people to do more work.
Okay. Sir, I have last two political questions for you.
Yeah.
One is, what is your take on EVM manipulation and electoral reforms?
See, electoral reforms is a subject I think which needs attention. We saw what happened in electoral reforms in terms of how the electoral bonds has been misused. It was open corruption actually, and used for all kinds of siphoning and money laundering basically. It was, you threaten people and ask them to take bonds and to invest in your to help your party. So that was one thing which ultimately Supreme Court came down. But cost of elections are going up. So how do we have a transparent system now?
Right.
See, electoral bonds was a horrible system which was brought about.
Yeah.
So we need another system now. So now you can't say we'll go back to the old system of again just trying to raise all funds through cash.
Right.
So we need to have a newer system. And elections also, the way that these things, the election commission is working, there I think there needs to be, we have to ensure that the independence of that has to be retained. Unfortunately, today it's compromised. And we see glaringly what all they do. And EVM, I don't know, people keep saying, but I have not found so far how it can be tampered on a mass, across. Maybe if you get a hold of, if I have access to an EVM, I can fix the EVM. That's possible.
Okay.
I have seen it also.
Okay.
If I get access to an EVM, I can manipulate that EVM.
Okay.
But the problem is you can't get, you don't get that access.
Right.
It is not, that access is not given to anybody. So I do not know how that works.
Okay.
So I have my doubts that, but if there are doubts, I think many countries in the world, they don't have not gone in for electronic voting because they prefer the ballot. Uh, because any electronic machine can be
Tampered, manipulated.
tampered with.
Yeah.
So even if out of 100 machines in one election, in one assembly, even if I tampered 5 or 10, that itself is
Right. Yeah.
not good, no.
Correct.
So that is a problem.
Right.
So, but I would not say that all elections are being won because of EVM tampering. That I will not
Right,
say.
right. So one last question: are you looking forward for a cabinet reshuffle? And if there is a change in leadership, would you want to change the role that you have now?
No. I am very happy with my head department. In fact, whatever experience I've learned in the last 1.5 years, I think I would want to continue so that I can do so many things are there in my mind now in our team that we are working on. So all those things I can, another year or 2 years, if I can work in the same department, definitely I'll be able to really carry it forward, carry it through. And then somebody else comes and takes over, they come up with newer ideas and they can do different things. But we have got a certain plan now. So I think I'm very happy with the department actually, because it's such a good department to work. So many things you learn, and it affects the people.
People directly.
It's
Yeah.
directly connected to the people. So any good thing that we can do will have a lasting impact. So that is the thing. So I don't think
Is there any reshuffle
I
happening?
don't know. I mean, that is left to the High Command and Chief Minister and all that. But that is their discretion. That they can do any time, I think. One never knows.
Right.
It can happen.
Right. Thank you, sir. It was wonderful speaking to
Yeah,
you.
thank
That is
you.
all we have for today. Thank you.